afternoon, and thank you for joining us for today's VIA VitaFlow in association with you webinar. My name is Michelle Harrington. I am a registered dietitian on the medical and scientific affairs with VitaFlow North America. We are excited to bring you this educational activity and introduce our speaker. Today's topic is innovative approaches to the nutrition management of pediatric acute kidney injury. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note, questions will be addressed during and after the presentation. Please submit text questions into the Q&A pane at any time during the presentation. If we get a lot of questions and we're not able to address all of them, please note we will connect with you independently after the program. You can access a PDF of the slides in the chat. CPE is not available for this program. Now I have the pleasure of introducing today's speaker, Marissa Juarez Calderon. Marissa completed her master's degree and dietetic internship at the University of Texas School of Public Health. She has been a pediatric nephrology dietitian at Texas Children's Hospital for over 20 years. In addition to her responsibilities at Texas Children's, she is currently the membership committee affiliate co-chair for the American Society of Pediatric Nephrology, ASPN. She has also served on the planning committee for the ASPN Multidisciplinary Symposium since 2013. Marissa co-authored the renal chapter in the American Society for Parenteral and Enteral Nutrition, ASPEN, Pediatric Core Curriculum. Her research topics include IDPN for hemodialysis patients, optimizing nutrition in AKI, the use of growth hormone in CKD, and prevention of malnutrition in the pediatric population. With that, I'd like to turn it over to Marissa.
Thank you, Michelle. Thank you all, first of all, for joining this afternoon and taking the time out of your day to hear me talk today about AKI and the nutrition management of AKI. The objectives of today's discussion are going to be to discuss the history of nutrition potassium management for chronic kidney disease, to review the nutrition challenges in the management of acute kidney injury, to discuss how Renastart and Renastep could be utilized in the dietary management of CKD and AKI. And then lastly, we're going to review a couple of case studies using Renastart and Renastep in clinical practice. So first I want to start by going over, this might be review for most of you, but just the role of the kidney in body homeostasis. The kidney does a lot in the body, and sometimes it's hard to believe that only one organ can do so much. One is fluid and electrolyte balance, this is us making urine. The other is waste removal, bone metabolism. The kidney is involved in calcium, phosphorus, PTH, and vitamin D balance, erythropoietin production, acid-base balance, and blood pressure. So next, I'd like to talk a little bit about the difference between CKD and AKI. CKD is the progressive decline in kidney function. In children, it usually presents at birth or in early childhood. Some of the pediatric etiologies include obstructive uropathy, dysplasia, and polycystic kidney disease. Even though it may not seem rare to us as practitioners in this field, it is a rare occurrence in children with a prevalence of about 75 in 1 million children. And it occurs in about 24,000 children in the US. And it is only 2% of the ESKD population. In CKD, recovery is not expected. Like I said, it's a progressive decline. However, the the progression of the disease can be slowed with diet, medications, and follow up with a nephrologist. On the other hand, AKI is an abrupt decline in kidney function. Some of the etiologies include sepsis, oncology treatments, cardiac surgery, transplantation, and nephrotoxicity, especially in the neonate. AKI occurs in about 27% of children in the ICU. And opposite of CKD, AKI is expected to have recovery. It's typically short term. However, although short term, it can cause increased mortality, increased length of stay, and ICU stay. And it also can have long-term consequences, such as having CKD and hypertension in a patient who didn't previously have that disease. So these next few slides, I'd like to thank Chris Nelms for allowing me to use these next few slides on the history of pediatric CKD management. So thank you, Chris. In the past, the only product for non-adults prior to the availability of Renasart and Venustat was Similac PM6040. And PM6040 is an infant formula, but was used post-infancy in pediatric patients due to the lack of a pediatric renal formula. So in order to manage potassium, clinicians had to either dilute products with a large amount of modulars. We had to use adult renal formulas. We had to use potassium binders, such as sodium polystyrene sulfonate. And we had to maybe give more dialysis or other medications in order to control potassium. PM6040 is low in phosphorus and also sodium and iron, in addition to potassium. However, it does have some disadvantages. Sometimes the sodium content is too low for kids with salt wasting, and in some cases, the potassium could actually be too high for some children. It was also high in vitamin A for most kids with CKD or AKI. And it also lacked a lot of essential fatty acids. It didn't have ALA, ARA, or DHA. As I mentioned, sometimes we would have to dilute products using modulars in order to make them tolerable from an electrolyte load or a renal solute load. But this can be very ineffective. The disadvantages of diluting products are that you potentially alter the macronutrient distribution ratios. You also provide inadequate amounts of vitamins and minerals, and it can also make mixing difficult. Many times parents would complain about the formula being either too thick or kind of gritty or something. And sometimes those difficulty measuring made it intolerable to the patient. When we look at a comparison of PM6040 that's concentrated to 30 calories per ounce, or when it's PM6040 at 20 calories per ounce concentrated to 30 calories per ounce with DuoCal, we can see that there is a difference in the macronutrients that are provided. And according to the PRNT article on protein requirements for children with CKD, we know that higher protein is needed for patients with CKD. And with the studies that they referenced showed that a diet with about 5.6% of calories from protein, there was a lower standard deviation score of length and growth velocity. So when we dilute with a modular, we get around that same amount of distribution of protein, and this can not be sufficient for a patient with CKD. And so, we need to keep in mind that concentrating the actual formula would be an adequate amount of protein. However, sometimes they may not tolerate the amount of potassium or the amount of magnesium or something else. So it's not to say that you can't concentrate with a modular. It's just keeping in mind that a modular for protein might actually also be needed. When we use adult formulas, there's also can be issues. And the fact that many adult formulas do have maybe too high a potassium content for a child. In one study, they looked at 7 hyperkalemic infants that were prescribed an adult renal formula, which actually lowered their potassium and promoted growth. But most of them also had other issues. Some of these formulas tend to be very high in fat, and in many younger children, they don't tolerate the high amount of fat. So again, then you end up diluting with a modular, and as the previous slide suggested, you can have other insufficiencies. You can use them also to mix with other products such as a PM6040. That can also, you can also do that, and that's fine, but just again, you're mixing with another formula. They're also used as a transition product when a child is aging out of infant formula. And as I mentioned, PM6040 is an infant formula. So at some point, it becomes inadequate for an older child. One of the things that you might notice clinically is the child may start to have poor growth or need a lot of modulars to meet their needs. And these are all signs that a child might be aging out of that infant formula and it's time to transition to something different. There are some disadvantages to using adult renal formulas. One that's very clear is that they're designed for adults. And so some of the nutrient profiles for children are not favorable, specifically in magnesium, vitamin A, and the protein. They're often not, as I said, they're not well tolerated. They might have too high of fat. They are also designed for adult needs with features like carb steady that aren't needed for children and may not provide a favorable macronutrient ratio. Okay. So this next slide shows us how Suplena can provide too much protein for a toddler based on 1,000 calories, which is about the needs for most toddlers. Suplena is an adult formula, and it's designed for pre-dialysis adults. It does have lower protein than other adult renal formulas. But in the case for children, as you can see here, the DRI or CPR range for a toddler is 11 to 15 grams of protein, and Suplena would provide 25 grams. And this can maybe potentially be too high for a toddler or a young child. As you can see, it also has other higher amounts of other nutrients such as magnesium, vitamin A, and vitamin E. And one of the things that I think you have to remember about magnesium is that magnesium can also be troublesome with a child on dialysis. And remember that, especially on PD, because the PD dialysate contains magnesium. So that's another contributor of magnesium to the child. So you have to just keep those things in mind when prescribing these formulas. So one of the ways that we can control potassium is with a potassium binder, such as sodium polystyrene sulfonate or SPS. It can be given orally, rectally, or used to decant formula or any other liquid to reduce serum potassium. The decanting is done to reduce the potassium content of formula prior to consumption. And the process of decanting involves adding the SPS to the formula or the breast milk or any other liquid, putting it in the refrigerator for 30 to 60 minutes and letting it decant. And what that means is at the end of the time, there will be sort of a brown, sludgy material at the bottom of the container that the formula was in. And you just pour off the formula at the top, leaving the brown sludge at the bottom. And then that formula is said to be, with reduced potassium. And so in studies that have done studies on decanting formula, they have shown to reduce potassium by as much as 24%. So it is possible and it is effective. However, it is quite it's quite tedious. It's a quite tedious process, and we've done it in the past, but I'll talk about that a little bit later. But we really don't recommend doing that in our unit at this time. The other thing about oral, it can be given orally, and the taste is not very great. And also, many parents say that the patients have increased stooling when it's given orally. There are also risks of using SPS. The main ones are listed here. We have bowel necrosis, gastrointestinal obstruction with oral or rectal use. There are many opportunities for errors in mixing and measuring and the decanting process. As I said, it is very tedious, and so that tediousness also lends to having more errors in the process. It has been shown to be ineffective in some formulas. It also is a sodium exchange product. So although you're decreasing the potassium, you're adding a lot of sodium. For some patients, this may not be as much of a complication, especially if they're already on sodium supplements, and you could just adjust that supplementation. However, for some other patients, it could be quite troublesome, and so you just have to keep that in mind. It also has been shown to alter other nutrients. In this study by La Palma, they did find that there were 14 patients who received 19 courses of SBS pretreatment of their enteral formula. And these formulas were various formulas that were evaluated. The serum electrolytes were evaluated at baseline and then 1 week after initiation of the therapy. Even though the serum potassium levels decreased from 6 to 4.4 millimoles per liter, the serum sodium levels increased from 135 to 141. And half of the courses resulted in electrolyte abnormality of calcium, sodium, and potassium. So the calcium was reduced, the sodium was increased, and the potassium was reduced significantly. So there were some adverse events that were described in this study. Some of the adverse events that were included were severe hypokalemia, hypocalcemia, diarrhea and emesis, myalgias and fatigue, and respiratory distress. And at least half of the discontinuations were due to these adverse effects. So as I mentioned, there can be nutrient alterations in these formulas. I mentioned that there are reduced vitamin and mineral levels in calcium, copper, manganese, zinc, and phosphorus. Even though most of the studies showed reduction in phosphorus, the La Palma study actually found an elevation in phosphorus levels with the SBS treated formula. There can also be increased values, and those were found in iron, sodium, sulfur, pH, and aluminum was quite just significantly increased by 500 to almost 4,000%. And we all know that aluminum can be very toxic with patients with kidney disease. So the big message here is that a major challenge in modifying formula nutrients is the inability to quantify the specific changes, right? So we don't know. These are big ranges that I have up here. And so we don't know what each case is going to do. And this makes it very complicated to make dietary adjustments and to manage the prescription of these supplements, especially for things such as iron and phosphate, where we're constantly looking at these lab values and making adjustments. So there are, the PRNT does have some recommendations. This is in the article that's listed below. First, we're going to look at dietary assessments for potassium sources. And then sometimes we forget about this. We forget in step 2, which is why it's highlighted, is there are sometimes other non-dietary sources for hyperkalemia, mostly medications, maybe even poor dialysis, like not having adequate dialysis clearance. So these are areas that could potentially be corrected and could fix the potassium. However, if this step doesn't fix the potassium, then we might need to look further. We might look at dietary management and possibly making alterations in the formula or breast milk to reduce the potassium. We also want to look at if the patient is on solid food and making maybe further changes. Maybe the patient previously had urine output and now no longer has urine output, and so that would cause maybe some changes in the potassium and maybe some further decreases in their diet are needed. And then lastly, the very last sort of step is to recommend a potassium binder. I will say that, and I'm going to talk about this a little bit later, but I would say that given the availability for products like Renastart and Renastep, for our solely tube-fed patients, we typically do not have to use potassium binder at all. So next, I want to talk a little bit about AKI diagnosis and awareness. The KDIGO criteria defines AKI in children and neonates. KDIGO utilizes both serum creatinine and urine output criteria for defining AKI. It is imperative for U.S. dietitians to understand the diagnostic criteria as it not only to better understand the disease process, but also to understand lab values and what's happening with the patient. AKI as a whole is often underdiagnosed, especially in acute care areas versus the intensive care areas. ICUs, in acute areas, they report a minimum of about 5% of AKI incidents. But in a study by McGregor and colleagues, they found that only about 15% of patients had two serum creatinine values that could be analyzed. Additionally, in pediatric ICU settings, researchers have found that serum creatinine alone fails to identify 2/3 of patients with AKI. So it's very important to also look at urine output. AKI remains important to identify early, and research remains ongoing in this aspect. At this time, AKI management is primarily limited to reducing the risk factors and providing supportive care. And this is where pediatric and neonatal dietitians are needed to continue to allow for optimization of nutrition within this setting. This next slide reviews AKI epidemiology. AKI, there is a high incidence, about 30% of AKI incidence in ICUs, and it increases with longer admissions. There's also an increase in mortality. As I mentioned there in the previous slide, there is higher mortality, about 15% in ICUs and about 10% in acute settings. And in these cases, these patients typically also have the highest need for renal replacement therapies. Hospitalizations are complicated by AKI because hospitalizations complicated by AKI has significantly more diagnosis, chronic conditions. They also have more procedures documented at discharge. These patients with AKI are 20 times more likely to experience extreme loss of function, and they're over 40 times likely to have a likelihood of dying. So there's also been reports that urine output alone confers an increased risk of death. So all of these things are very important to consider when you're evaluating your patients and how you're going to treat them. There's also strong evidence that for the notion that in the hospital setting, children are developing AKI because of systemic diseases. They're also injury to other organ systems, and treatment required to manage disease states rather than the primary renal disease. By age, children that are over 1 month old tend to have AKI associated with shock or sepsis, liver disease, respiratory failure, and being on mechanical ventilation. Not surprisingly, nearly 1/4 of AKI hospitalizations receive concomitant intensive care, and this figure reached 70% among children less than or equal to 1 month of age, establishing the ICU as a primary setting for neonatal AKI. And even though sepsis, liver disease, and mechanical ventilation were associated with neonatal AKI, There's also been studies that suggest that cardiac disease or cardiac surgery are also very highly associated with AKI in this age group. So next I want to talk about the goals of nutrition therapy and AKI. First, we want to avoid, the very first thing we want to do is avoid additional metabolic derangements. Typically, when these kids come to us, their labs are already out of sorts, and we're trying to just prevent any other derangements that are going on. The second thing that we want to do is we need volume control. As I stated previously, fluid overload has, I don't know, fluid overload is also associated with lots of morbidities and mortalities. So we do definitely want to get fluid control established. And then the third probably prioritized goal is to provide optimal nutrition and energy, protein, and other micronutrients. And then after we establish those three things, we can move on to the rest of the list by preserving lean mass, maintaining nutrition status, support wound healing and immune function. We want to reduce mortality, attenuate inflammatory status, and preserve functional status. So first and foremost, it's very important to establish collaboration with your healthcare team, both during admission and post-admission. And I'm going to make this statement a couple of times during this presentation because I think it is very, very important to make sure that you do not discharge a patient on Renastart or Renastep as a sole source of nutrition without dietitian follow-up. And that is because, and we'll talk about that a little bit later, but I'm going to go ahead and set the stage here that we want to make sure that these patients are followed up post-discharge. So once we've collaborated with our team, one of the next steps is, obviously having a full nutrition assessment. We do have shown in studies that 30 to 55% of malnutrition, there is an incidence of malnutrition in children with AKI on continuous kidney replacement therapy. It is important to, as I mentioned, most of these patients do have volume overload. So it is very important to estimate a dry weight for the patients and use that dry weight in your nutrition assessment. Feeding modality is, we know that enteral nutrition is preferred over parenteral to preserve gut integrity and prevent gut atrophy. If we can, we definitely want to use enteral nutrition within 24 to 48 hours of admission. You can use a polymeric formula based on individual needs. Typically, almost always, a renal formula is not needed if the patient is on CKRT. I would say probably the only caveat to this would be if maybe they are not on 24/7 CKRT, maybe they are on reduced time, maybe like 12 hours or something like that. There might be a possibility of the need for one, but in most cases, one is not needed. Our goal in this case for enteral nutrition is to reach 60 to 70% of energy needs by day 7. Now, if enteral nutrition is not suitable, then we would want to start parental nutrition. And the guidelines for parental nutrition is to start by days 2 or 3 for infants and toddlers, and by days 3 to 5 for adolescents on CKRT. There are some studies that show that parental nutrition during the first week of ICU is not necessary or warranted. And the theory behind this is that during the acute phase of critical illness, catabolism may be a part of the natural protective process called autophagy. And by providing parental nutrition, we are disrupting this process, thus inducing increased morbidities that were found in the studies. However, this is up to your institution to decide what you would want to do because it's not completely conclusive. I would say that, however, though, for patients that do have AKI and are on CKRT, there are so many losses that you probably do want to think about starting sooner rather than later. For those with AKI, there's also typically some increased gastrointestinal dysmotility. And so that may also warrant the need to start parental nutrition. Okay, so for our energy, the gold standard for our prescribing energy needs is to use indirect calorimetry. However, if it's unavailable, equations such as Schofield is appropriate. I will say that at TCH, we used to have some ventilator systems that provided VCO2 calculations, but we don't have those anymore. So we really don't, and we don't have access to an indirect calorimetry. So if you do, great, but if you don't, still okay. For protein, we do know that patients with AKI do have high protein needs to account for the losses with dialysis. RANA is the source for these needs that are presented here. That RANA's consensus group determined the protein needs by augmenting the Aspen critical care guidelines, and they came up with these numbers that are presented here. For carbohydrate, we want to provide 20 to 30% of the total energy intake. I will want to note that CKRT does stimulate heat loss, which is known as dialysis trauma, that can contribute up to 1,000 calories per day of losses. So keeping that in mind, that your needs also, you might need to take into account for some of these things. The other thing to consider is the additional calories that you get from the CKRT solutions. They can contribute anywhere from like 100 to 200 calories per day. It just kind of depends on the size of the patient and how much they're getting. But I have seen some larger patients, it contributes sometimes up to 500 calories a day. So it can be a lot. So just keep that in mind. Next, I'm going to talk about lipids. Lipids should contribute 30 to 40% of the total energy intake. Most of our patients, like I said, will probably require parenteral nutrition, especially if they have any GI issues or recent surgeries. And as a transition to enteral nutrition, parenteral nutrition is continued to ensure that their needs are met while getting to goal feeds. One of the things to keep in mind, if they are on parenteral nutrition, is that a multi-component lipid, such as SMOF, is better tolerated because it has anti-inflammatory effects. The recommendation is to start with 1 gram of fat per kilo per day and gradually increase to 2 to 4 grams per kilo per day over several days. In the GIST study, for fluids, typically fluid restriction is not needed on CKRT. Prior to starting CKRT, you may need to concentrate feeds. However, once CKRT is started, you do not need to restrict fluid. In the GIST study, they looked at patients who had fluid overload and AKI. They looked at 4 phenotypes. They looked at no fluid overload and no AKI. And they looked at no fluid overload with AKI. They looked at fluid overload with AKI, and they looked at fluid overload and AKI. And what they found was that fluid overload with AKI was associated with increased length of stay and mortality. These patients had a 23.3 odds of death compared to patients with no fluid overload or no AKI. So again, highlighting the importance of volume control in these patients when they have AKI, and even if they aren't CKRT, there's a need to make sure, even though they're not on a fluid restriction, there may need to be a little bit of one in the beginning just to get them euvolemic and then maintain. All right, so now moving on to micronutrients. Typically, patients who are on renal replacement therapy will have lots of losses, especially of water-soluble vitamins and minerals. And so ones that we need to think about are any water-soluble vitamins, selenium, copper, zinc, and carnitine. For potassium, we want to avoid rapid repletion of potassium if they are found to be hypokalemic, because this can be very deleterious. For phosphorus, it is okay to supplement through the dialysis fluids. If you have a patient who has had some GI intolerances, enteral supplementation may not be tolerated and could actually cause more GI irritation, such as diarrhea. So keep that in mind when supplementing phosphorus. And then carnitine. Um, uh, ScanBat's study has shown that amino acid um, losses and deficiency can occur by week 3 of CKRT. So there is limited data on supplement dosage, but it should definitely be considered. It is something that we consider with all of our patients that are on continuous renal replacement therapy. So next I want to talk about when to use parenteral and when to use enteral. Here on the left, we have all of our indications for parenteral nutrition, and those include hemodynamic instability, high-dose vasopressors, required NPO, ileus, GI intolerances, oral or enteral nutrition is insufficient to meet needs, malnutrition or risk for malnutrition, and also being on continuous renal replacement therapy with or without malnutrition and needed to start parenteral nutrition before 1 week. And then starting indications for using enteral nutrition would be those who are hemodynamically stable. They are on no or low dose vasopressors. Costs might be considered. It was listed in the article, but for most institutions, it's going to be used even if there is a cost. If there are no known GI intolerances, it is the preferred method of providing nutrition. So if it can be done, and none of these indications for parenteral are there, then definitely we want to use enteral. And even if feeding through the gut we can consider going post-pyloric if needed to ensure that tolerances are there.
Marissa, we got a question.
Yes.
What do you use, what parameters do you use to determine hemodynamic stability and instability?
Great question. One, they're going to be looking mostly having to do with blood pressure. Are they on a vent? Do they have risk for aspiration? Things like that. Does that answer the question?
I think it did. If we
Okay.
get more, I'll let you know. Thank you.
Okay, thank you. Yeah, please post your questions. I'm happy to take them as we're going through the presentation. Okay. So this slide is from Yee's article on enteral feeding. This is a very nice chart that we use here to advance enteral feed, to start and advance enteral feedings, both bolus feeds and continuous feeds. It's a really nice chart as a guideline to get started. I would say for neonates, when we're talking about maybe transitioning from parenteral to enteral feeds, we like to stop lipids when enteral feeds are about 80 mLs per kilo per day, and then we'll stop total parenteral nutrition when enteral is about 100 mLs per kilo per day. And then in the pediatric setting, we typically stop parenteral nutrition once enteral is meeting about 80% of needs. Okay, so now I want to talk about evaluating and assessing your feeding modality and timing. We also have to consider how the patients are being fed. On the graph on the left, this is from the Meta article. Meta showed a dose response relationship with enteral protein provision and 60-day mortality in critically ill children. They found that enteral protein provision increased mortality. Whenever they had a higher dose of protein, they had lower mortality. And then on this slide on the right, this was our study that we did here at Texas Children's. We have to, and what we were looking at was the percentage of timing to meet protein goals. And so when we looked at patients that were only getting protein from TPN, only getting protein from their tube or oral feeding, or if they were getting it by combination of the two, of both TPN and tube or oral feeding. And what we found was that those who received oral or enteral feeds met their protein goals less often, as you can see here, than when they were receiving a combination of both TPN and enteral feeds. When we dug deeper to look at what happens when we try to wean TPN, we found that the protein intake decreased to 20.5% when we weaned. So it is very important to consider your weaning process and making sure that you do it just at the right time to prevent giving too less of protein. So talking about initiating and advancing enteral feeds, I am a very firm believer in trying to make one change at a time. We typically like to increase volume first at standard concentration, and then once we get to goal volume, increase concentration. It is very important to monitor tolerance. So you still want to monitor growth. You also want to monitor GI tolerance. Is the child having diarrhea, constipation, vomiting, abdominal distension, etc. We also want to look at electrolytes, minerals, and fluid imbalances to ensure, that patients are tolerant, because there's going to be changes in their kidney function, right? And so there can be tweaks and changes sometimes on a every other day basis based on how their kidney function is going, or either recovery or not recovering. Okay. And then before discharge, you want to ensure that the patient is tolerating their home regimen. I'm a very much a believer in ensuring that this happens, because the one thing that you don't want to do is send a patient home on a regimen that you haven't seen justified, like they're tolerating it before they leave the hospital. You're sending them home on something that you just made changes on and you're not able to tolerate. Like, you're not able to tolerate GI issues. You're not looking at their labs the very next day or anything like that. So I'm very, very much adamant about making sure that the home regimen is tolerated before discharge. Okay, so next, I want to talk a little bit about preparing for transition off of continuous renal replacement therapy to intermittent HD. An intermittent HD could be anything from daily HD, which would be just for a few hours. It could be for every other day. It just kind of depends. It's intermittent. It's not going to be constant. First and foremost, you're going to have to fluid restrict. Depending on it, this is going to depend on urine output. It is liberalizing fluids is easier and faster. You also need to think about the fact that it's easier to add free water than to take it out. So just keep that in mind when thinking about how you're going to ensure euvolemia. Building a nutrition plan that is easily modifiable. You want to consider using a low solute renal formula in combination with a regular formula. Again, liberalizing is easier than removing them. So it's much easier for me to give a little potassium if they become hypokalemic versus to take it away. then you're potentially having to make a patient NPO, right? Because the formula that you gave is too high, right? So you're having to make them NPO. Versus if you give them something that's a little bit lower, you can supplement it and not have to make them PO. They can continue what they're doing and you just give them a supplement. Let's see. Next, it's really important to remember that patient needs remain extremely dynamic and need close follow-through. Like I said, their kidney function can be changing on a day-to-day basis. So it's very important to closely watch their electrolytes, watch their I's and O's. Also look at the frequency of intermittent renal replacement therapy. Sometimes a patient will go from having daily HD to maybe having like every other day HD. So that might make changes. That might make the need to make changes again. Also, if the patient is on diuretics or they're having a diuretic challenge, so keeping those things in mind as well. And then lastly, making sure that you can maintain communication with all teams. And as many of you all know, working in an ICU, typically you're not just working with your team, you're working with multiple teams, and everyone needs to be in communication and on the same page about what the plan is. Okay, so once a patient is on intermittent HD, we have to evaluate fluid. Fluid is assessed by, number one, looking at the frequency of dialysis. As I mentioned before, the frequency can change depending on what's going on with the patient. We also need to look at the ability to ultrafiltrate and the hemodynamics. As I said, some patients might, they may have lower blood pressures, for example. They may not be hemodynamically as stable and have lower blood pressures, which may make it very difficult to ultrafiltrate fluid off of these patients. So you have to take that into consideration. Another thing that you need to think about is sometimes these patients will have shorter HD sessions initially, and then gradually they will be increased as tolerated. You don't usually see a patient go full blown, with a 4-hour treatment or something like that. So you have to keep that in mind. The other thing that you have to keep in mind with dialysis is the rate of fluid removal. Studies have shown that we really want to keep that rate to less than or equal to 13 mLs per kilo per hour in order to prevent cardiovascular complications, such as myocardial stunning. So if you have a patient that is very fluid overloaded and you're trying to keep them at this rate, it might take a few days to get to your goal weight. So just keeping those things in mind. The other thing that you want to look at, of course, is urine output. Maybe the patient was anuric and now they're starting to have some urine output. So keeping that in mind as well and assessing that and looking to see the changes that are happening on a day-to-day basis. You also have to think about insensible losses and medications. Medications can contribute to a substantial amount of fluid in some patients. So keeping that in mind as well. And again, discussing with your team about what your fluid goals are and how you can manage those together. As I mentioned, with transitioning from TPN to enteral nutrition, we want to concentrate after we get to our volume. Typically, we try to do a 1-to-1 wean when we're at 60 to 75% of concentration. Oops. Oh, okay, there we go. Okay, so next I want to talk a little bit about our products, Renastart and Renastep. These are both flexible, convenient formula options that can be used to control electrolyte and mineral content. Renastart is a powder that can be used to concentrate other formulas or in combination with other formulas to control electrolyte and mineral content. And Renastep is a ready-to-drink formula that can be used to control electrolyte and mineral content, and also great for patients who are fluid restricted. And it can also be mixed with other formulas to control electrolyte and mineral content if not given by itself. Okay. They can both be used solely in some cases um, for the management of AKI and CKD in dialysis, and in the case of maybe a failing transplant. These are the first and only pediatric renal formula options that are available, and they are suitable from 1 year of age for oral and tube feeding. So you might be asking, when do I use Renastart and when do I use Renastep? As I mentioned, they can both be used for volume restriction. They can both be used for a potassium restricted diet, and they can both be used in AKI. Renastart should be used with parents of young patients who are familiar with the powder product, and maybe they're transitioning from something like a PM6040. It is the first line of nutrition support for patients where biochemistry is not stable and needs careful monitoring for formula titration. As I mentioned many times, when you have AKI and maybe you have recovering function, you might be titrating formula every day, every other day, because their chemistries are changing daily. Renastep is great to use with patients who were previously on Renastart and are willing to try a ready to feed or ready to drink formula. And it can also be used when the biochemistries are stable and they're not requiring frequent formula tweaking. So next, I'd like to talk about some case studies. I have 2 case studies to present today. This first one is EP. And in this case study, we're using sole Renastart to prevent the start of dialysis. And I do want to say, I want to be completely transparent that this case study is based on a real case, but some of the information was modified for educational purposes. So this little guy, he was born full term. He had a prenatal diagnosis of bilateral hydronephrosis that was noted on prenatal ultrasound. He had grade 5 vesoureteral reflux with hydronephrosis and also trisomy 8 mosaic schism. He was discharged from the NICU with CKD3, and at this point in time, he is a toddler, and he's been admitted with stage 3 AKI on CKD. So basically what that means is that he already had CKD, and now he's had an exacerbation with AKI, and he's been admitted. And so the thought is that even though he already has a baseline of CKD, the hope is that he will, because AKI is recoverable, that maybe he'll go back to his baseline CKD. But in this case, he did not, and we're going to go through that in just a bit. He also has a swallow impairment. He had oropharyngeal dysphagia diagnosed with video fluoroscopic swallow study. And he was shown to have silent aspiration for all liquids except IDDSI level 1 or thickened feeds that were only allowed with a speech therapist. He is GJ tube dependent and vent dependent. So what I'd like to show here is that before he came to us, before he was admitted to the hospital, he was on a mix, an equal mix, well, not an equal mix. He was on a mix of 2 feeds of Renastart with 6 feeds of Enfamil Gentlease, and he was receiving approximately 1.8 MEQs of potassium per kilo. And this, I'll remind you, he was about a CKD3. And when he got admitted, he was admitted with AKI, and he was on those same feeds. However, within about 1 week of being in the hospital, he was transitioned to all Renastart because of hyperkalemia. And phosphorus was still acceptable for his age, but definitely the potassium posed an issue. And so he was transitioned. And with that transition, he was only being provided about 0.5 MEQs of potassium per kilo. And I will say that intermittently throughout his course, he would have some gentlies added back to his feeds because he would have hypokalemia. However, within a few days, he would become hyperkalemic again, as is the case that happened here. And so he would have to go back to all Renasart feeds. And so that became quite tedious and troublesome for the teams managing him. And so it was agreed upon that we would keep him on all Renastart and just supplement the potassium as needed. I mentioned this a few slides ago that it's much easier to give a supplement than to take it away. And so this would prevent having to make an NPO because the formula that was already mixed for him had too much potassium. And so we would have to wait for the next batch, the new batch to come out to feed him. And so by collaborating with the teams and establishing the plan to just supplement potassium as needed in order to prevent making him NPO or anything like that, that would be the plan. And so you can see here that he stayed on all Renastart feeds through the month of August here, keeping potassium about 0.5 MEQs per kilo for the duration of that time. Let's see. He also, he kept stayed on all Renastart, but the concentration of the feeds was gradually increased to promote growth and to ensure that all of his needs were met. He also had some fluid overload. So over time, we also increased the concentration, not only to promote growth, but also to decrease the volume that we were giving him. And that was where he sort of landed here in September, was at Renastart 28 kcals per ounce. And he was on, at this point, he had just been converted to an NJ tube. As I mentioned, he had some signs of silent aspiration. And so, post-pyloric feeding was definitely medically appropriate for him. I would also like to add here that he was on continuous feeds, but he had breaks so that we could give him calcium supplementation as a calcium supplement. If you are new to the practice, you'll know that calcium carbonate can also be used as a phosphorus binder. And in his case, we did not need him to have a phosphorus binder. He needed the calcium as a calcium supplement. So in order to give that appropriately, it needs to be given without feeds. And so his feeds had breaks in them so that we could give him the calcium supplementation. So by the beginning of October, his feeds were concentrated to 30 calories per ounce because he had some poor weight gain noted. As you can see, we were still able to keep potassium and phosphorus at normal limits for his age. Again, he was still only receiving about 0.5 MEQs of potassium per kilo with potassium supplementation given as needed. Later in the month of October, he had a PD catheter and G button placed. And by the end of November, he was started on peritoneal dialysis. And as you can see, this is about day 4, his PD was started on 11/21, and by 11/25, we were already needing to change his formula by adding some gentlies to give him a little bit more potassium, and because his potassium was low. And you can see we went from about 0.5 to 0.8 MEQs of potassium per kilo. And then over the next 10 days or so, 2 weeks or so, we gradually increased the amount of gentlies because he was on PD. And we were doing this to maintain his potassium levels without giving us much potassium. At this point in time, we knew that he needed more potassium. He was going to need more potassium on a consistent basis because he was on PD. And at this point, he was getting about 1.4 MEQs per kilo. And so you can see that over time, we pretty much kept him on the same formula. We eventually also added protein because he needed more protein. We noticed a low BUN, but throughout this whole period of time, we kept him on about 1.4 MEQs of potassium per kilo. And then finally, when he discharged in February, we had him on a combination of Renastart and Gently's and protein with that same amount of potassium.
So we have a question.
Yes.
This is from Emily.
Yes.
How long do you recommend for the feeding breaks to supplement with the Tums, the calcium carbonate?
About 2 hours.
2 hours. Thank you.
Yeah. At least one, but if you can get away with two, even better. And for this child, we were able to do that. Okay. Next, I want to show you the VitaFlow DRI calculator for this toddler. At about 820 calories, you can see that he is meeting his needs for almost all the nutrients except for the ones that we purposely want to decrease, which are vitamin A, calcium, phosphorus, sodium, potassium, and chloride. And I mention this because there is a lot of confusion around the use of Renastart and providing adequate nutrition. The statement that Renastart is not nutritionally complete refers to the electrolytes and minerals that we are wanting to lower for kidney disease. So yes, this formula wouldn't be nutritionally complete for a patient without kidney disease, which is why it's not available without a prescription. This chart, as you can see, we are meeting his needs. And so, it from that perspective, it is nutritionally complete. And I will say that, he did, like I said, intermittently need some potassium supplementation. He also needed some phosphorus supplementation and calcium supplementation, but we were able to control that from a medical standpoint. It's, like I said, much easier to give it than it is to take it away. And then also, once he was on dialysis, we also gave him a renal multivitamin. Okay, our second case study, and I know I'm running out of time, so I'm going to go through it pretty quickly. This is a otherwise healthy 3-year-old who was admitted with Shiga toxin producing E. coli that was associated with hemolytic uremic syndrome, or HUS. The problems that she presented with were bloody diarrhea, fluid overload, and electrolyte abnormalities. She developed severe colitis status and ended up having to have a total colectomy with ileostomy. She did require CKRT. And I will mention that prior to admission, like I said, she was an otherwise healthy 3-year-old and was a great eater. So when she was initially started on CRT, she was on parental nutrition. And as you can see, she was not quite meeting her needs. The advancement of her feeds was delayed. She also had to have her lipids held at some point because she had high triglycerides. But eventually, we were able to transition her off of the parental nutrition. And the reason, obviously, why she was on parental nutrition was because she came in with bloody diarrhea. So once we transitioned her off of parental nutrition, she was put on Peptamen Junior high protein via NG tube. And you can see here that at that point, even when she was on parental, we were giving her, a pretty hefty good healthy dose of potassium at 2.5 MEQs per kilo. Once we were getting ready to transition her off of CRT, and onto for intermittent HD, at this point, this is where all that planning comes into play. So we definitely wanted to make sure to reduce her potassium and phosphorus and other electrolyte and mineral intake. And we did this by combining Renastep and Peptamen Junior 1.5. As you can see, we were able to keep her potassium and phosphorus within normal limits. We also had to decrease the volume that we were giving her. As I said before, on CKRT, we don't have to modify volume. We can typically we have to give higher volume, but in her case, and then once we transitioned to HD, we had to lower the volume. And you can see here we dropped from about 2.5 MEQs of potassium to 0.7 per kilo. At this point in time, we also did still keep her on levocarnitine because she was still receiving HD. And once she transitioned off about, let's see, about a week later, we were able to transition her off of HD completely on Renastep and a combination of Renastep and Peptamen Junior 1.5. And we were able to keep her K and phos within normal limits. She was still on reduced volume, and the potassium was about the same as it was when she was on HD, but because she did have her kidney function came back enough that she didn't need dialysis. This is a level that she was able to tolerate. And then to give a current update to date, she still requires, she does have CKD and she still requires a potassium restriction and is supplementing her oral diet with one Renastep per day. So this is, lastly, I just wanted to go over monitoring while on CKRT. We do want, as much as possible, I know it's really hard sometimes to get daily weight checks, but as much as possible, we like to get daily weight checks, both pre and post dialysis, whether they're on HD or PD. We also want daily lab checks while inpatient. Sometimes if they're on a stable regimen, we can go maybe every 2 days after changes are made. But typically when they're inpatient, we're typically getting labs almost every day. Outpatient lab checks may be weekly, and then we can transition to monthly or after changes are made. Whenever my patients leave and I make a change, I ask them to come back in 1 week for a lab check. They may not have a visit with their nephrologist in that 1 week, but they'll just come for a lab check. Very important because sometimes we might overshoot or undershoot, and we just need to make sure that we're monitoring those changes very closely. And I mentioned earlier, and I'm going to mention it again, we absolutely need dietitian follow-up when a patient is on sole Renastart due to the low potassium. There are lots of detrimental complications that can occur with low potassium, low serum potassiums, and those include heart failure, arrhythmias, muscle weakness, cramping, paralysis, rhabdomyolysis, and GI issues such as constipation and respiratory issues. And that was my last slide. So thank you so much.
Marissa, thank you so much for such an informative presentation. We
Yes,
do
thank you. Sorry I went over a little bit.
No, it was fascinating. We do have a couple questions.
Sure.
And the first one I can answer, someone wanted to know how to get the DRI calculator. So
Oh,
that is available through our VitaFlow Via website. So you just go to www.vitaflowusa.com. And then at the top, there's a tab to go on to Via. Via is only for healthcare professionals. You do have to register, but it's free. And then what's really nice about the calculator, because I'm a big fan of saving time, you put in the number of calories coming from Renastart or Renastep, and then it populates all of the micronutrients. So if you just do that and you're like, oh, I'm at 80% of zinc and I know I'm giving another formula, it's a little shortcut. It only does do our products.
and it's
Then,
very easy to use.
yeah, it's really easy to use. Great tool. Um, okay, Rachel would like to know what dose of carnitine supplementation do you usually provide?
We usually start with 10 milligrams per kilo per day, and we'll go up to 20 sometimes, but we
Okay.
start with 10.
Okay. Let's see if we get any other questions.
Sure.
I do not see any other questions. So, at this time, unless we get one while I'm speaking, I just want to thank the audience for your participation. I want to thank Marissa for this wonderful talk. We really hope the information was helpful to your practice.